Welcome to our panel, Casting Patients as Consumers. I'm Constantia Petrou. I'm a GSB alum, class of 2002. And I started a company that caters to patients and families. This is why I'm moderating this discussion today. I'm joined by 4 experts in this area. And before I have each one of them introduce themselves, I'd like to share a couple of opinions that appeared in the New York Times recently regarding the healthcare consumer space. I believe these opinions set the stage for our discussion, and they bring some interesting polarization issues. Paul Krugman, an economist and a Nobel laureate, had this to say about healthcare consumerism. Consumer-based medicine has been a bust everywhere it has been tried. Decisions often must be made under conditions in which the patient is incapacitated, under severe stress, or needs action immediately with no time for discussion, let alone comparison shopping. At the other end of the spectrum is Frank Moss, a technologist. We are in the early phases of the next big technology-driven revolution, which I call consumer health. When fully unleashed, it could radically cut healthcare costs and become a huge global growth market. So, given these polarized views, today we'll discuss with our panelists what the opportunities are for technology companies in the healthcare consumer space. We have with us today Ron Goodman. He is the founder and CEO of HealthTap, and he will be sharing the entrepreneur perspective. We have Lamont, a managing partner at Oak Investment Partners, and she will be representing the investor's perspective. Bassam Kadry is a physician at Stanford Medical School, and he will be bringing in some of the realities that he faces in the doctor's office as he interacts with patients. And finally, Kelly McGonigal is a health psychologist and a lecturer at Stanford who is bringing an objective research perspective on changing patient behavior. I will let each of you introduce yourselves in about 5 minutes each, and then we'll proceed to questions from you. So let's start with you, Ron.
Sounds good. Hi, everyone. Good afternoon. And it's really a pleasure to be here back. Thank you to Stefanos and Garth and John Echemendy, who gave us a huge opportunity a few years ago to build together the Be Well at Stanford program and really engage a whole population around health and well-being at Stanford. And engagement is the key word of HealthTap, which is the startup that I started a little bit more than 2 years ago. And we launched our product almost 2 years ago, where patients or people can get health answers from physicians in minutes for free using their mobile devices, using a web browser from anytime, anywhere. We started with pediatricians and obstetricians, serving pregnant women and moms. In less than 2 years, we expanded our physician network to more than 37,000 US licensed physicians in good standing in 128 specialties and in all 50 states. In fact, we have physicians today in more than 3,100 US cities across the country. So you can go out to HealthTap and ask any health question that you have. You get an answer for free in minutes or in a few hours today. It's inspiring because I think that, Mark talked about it a little bit. There is a huge shift in how people expect to get health information today and from whom they expect to get information and how fast they expect to get their information and how fast they expect to get access to physicians, right? Mark talked about the use case of going to Google and looking for something and immediately finding what he wants, being able to order it at home. Imagine a world that you have a health question or a mom wakes up in the middle of the night and her baby is crying. It has very high fever. And she's concerned and she doesn't know what to do. She's going to run to the emergency room right now? Or is there a better solution where she can fire up HealthTap and push a button and be in front of a US licensed physician immediately and understand really well who the physician is, right? What are their credentials? How good they are in solving the particular question that she has, and have a quick interaction with them right from her mobile device in seconds. And HealthTap is building that today. And it's not doing it for one use case. HealthTap is actually serving millions of patients every month. We're serving many patients every second. We just celebrated more than 1 million active registered users on HealthTap. We have close to 8 million people coming to HealthTap every month right now, and 37,000 physicians serving them in a new paradigm that is really transforming how people get access to health information and to the best physicians in this country. The network, 37,000 US licensed physicians, are by invitation or by application only. It needs to be US licensed physicians in good standing. We check their credentials and we make sure that we give you access to the best physicians in this country. We've served to date more than 700 million doctor answers to patients. This is a huge number and it's growing really fast every day. So we are just across the street on University Avenue. We don't have 30,000 employees or not even 300 people in a strategy room working on what happens after Obamacare. We actually have only 30 people working on it, but mostly engineers, product people, and the designers who are really passionate about making a huge difference and serving more people in a new paradigm that will be mobile-centric and consumer-centric in a new way of getting immediate access to care anytime, anywhere.
Andy Lamont, managing partner of Oak Investment Partners. So we're a venture capital firm. I've been investing in healthcare for 31 years. And the way I think about this, the first 15 years was the biotech revolution. The next 10 years was reinvention of services. And really the last 12 years, we've been focused on technology-enabled solutions in healthcare. Because when you look at, Mark was a perfect precursor for this panel, because when you think about where the issues are with healthcare, it's wonderful to invent great products. I actually think if you looked at unfortunately most biotech products, there's been a lot of increase in cost and not a lot of gain from a lot of the investment that's been made. What we really need to do to improve healthcare is to lower cost and improve the process of healthcare, and that's where we're going to have better outcomes for people, and is going to be absolutely critical in terms of the budget deficit issue that we've got. So we started with Athena Health in 2000, invested in disease management, companies like Castlight. There's a common theme in our investments. If you look at 80% of investments in healthcare information technology the last decade from the venture capital community, it's actually they've been B2C investments. And I would contend that there may be some very interesting B2C models, but that the most interesting area is really B2B2C, because consumers do not pay for their health care. They are paying a higher percent. It will increase, but we are not healthcare consumers yet. We need to learn to be healthcare consumers. So we've been focusing on the employer market because the employer is the best and most direct access to the consumer. And I'll give you two examples. One is benefit focus. Mark referenced the marketplace that they have and consumers going online and essentially purchasing their healthcare benefits. Benefit focus actually powers that website for them and is the entire platform. If you think about the first act if you think about consumerization in healthcare, the first act is choosing your healthcare benefits. But most of us, I don't know how many of you know actually what your healthcare benefits are. You could say your deductible, your copay, it's sort of a patriarchal system right now where somebody else determines what that is. We get it, we don't understand it, and we don't have a relationship as a consumer in a transaction with healthcare. So that's the first act. So when I think of being a healthcare consumer, it's actually understanding what is your coverage and choosing it consciously. And I think with the advent of public exchanges and now private exchanges that Mark referenced with companies, we are going to start being healthcare consumers by simply understanding what is our healthcare insurance. And then secondly, the next act as a consumer in terms of a commercial transaction is the act of choosing a provider and choosing actually our drugs, determining whether it's a generic or not generic, and what is the pricing. And that many of you, I think, have been exposed to Castlight, but we're one of the investors in Castlight. And that, again, is through the employer system, because employers are really the only direct way to get and engage a consumer. Incent them in various ways to actually go and figure out in a reference-based pricing mode what a provider is going to cost. For example, if your wife was pregnant, you were going to be having a baby, you could actually see what are going to be the next 9 months of costs. What are the doctor's visits, the hospital visits, anesthesiology costs, the entire episode. What am I going to pay? What is the insurer going to pay? I think it's really, right now, I mean, it's so rudimentary. It's really getting that initial exposure so that you start thinking like a consumer in healthcare. And it's not just pricing, it really is quality. But we all, if you think about quality measures, as Mark referenced, people don't look up their local hospital and say, gee, what is the quality metric of this hospital? What is the quality metric of the doctor that I'm going to see? You really have to be part of an ecosystem that incents you to go do that and even think that way. And part of it is because we just don't think as consumers, and it's a very vulnerable thing to participate in the healthcare system. We listen to our providers. A doctor is a very important relationship. And it's amazing. Very smart people who are healthcare investors. I have the exact same relationship with doctors that you all do, and that is their God. When you walk in that room, they tell you something. We tend to believe it. We don't check out their references. It's just the assumption is they know what they're talking about. So I think it really is just the very beginning of thinking as a consumer in healthcare. And healthcare will never really approximate every other good that we purchase, but I do think that we have to start engaging in a different way with the system.
Hello, everyone. Thank you. Just a show of hands, how many physicians are in the audience? So at any time, if I say something that's not right, just chime in. The reality is that physicians spend more time in front of screens than they do with patients. And don't get me wrong, I think technology is great, but it's paper chaos has been converted to digital chaos. And a lot of that deals with the fact that priority is given to compliance and billing over usability. And unfortunately, a lot of providers modify their workflow to meet the limitations of the technology, as opposed to having technologies actually improve the way we deliver care. It's a really big problem. One keystroke could generate pages and pages of useless information, and the information overload problem is very serious. And part of that is that the complications that result because of poor information management in itself is a new barrier. And we keep trying to do things to compensate for that, but it's made it a lot harder. So I think one of the biggest challenges that participatory medicine helps address is this challenge of access. Physicians' time has become very, very tight because the reality is that most of their time is spent doing mandatory non-value-added activities that come at the expense of the patient, and they don't have much of a choice. And this is something that I think really gets underrepresented. You see all these technologies, all these screens, and they're sort of dependent on physician engagement, but it's just become almost a detour from the very essence of what most physicians really want to do, which is nurture that patient-physician relationship. So I would say that one of the things that really needs to be stressed in terms of participatory medicine is that it's a natural extension of our instinct for survival and our desire for happiness. Because if you can't get answers from your doctor, you're going to start looking for other sources. And physicians are no longer the sole source of validated information. There's other sources of very useful information. In fact, I think one of the most powerful components of participatory medicine is that patients are helping other patients. Physicians are learning from patients. This is very true for patients with terminal illnesses and rare conditions. And it's that type of engagement that I think is most hopeful in terms of all these types of technologies, empowering patients, providing them with information, and giving them choice. That's what patients want. They want choices, they want options, and they want information. And for physicians, being engaged in that process, it just matters of, is the technology simple to use, is it easy to use, and is it effective? It doesn't even have to make them more money. I'm honestly convinced, part of the reason why I'm here as a participatory medicine advocate is Stanford Medicine X is another conference that we have in September that was built across this whole principle, which is if we were to redesign this whole system with the patient at the center, how would we do it? Forget all the politics, forget all the issues that we're dealing with. Let's just start from scratch. And if we start from the patient as a natural focal point for that, why not have value, as Mark said earlier, value perceived from the patient's eyes and determine what makes sense to pursue. So I hope to give a little bit of that angle because I think a lot of things sound really good in theory, but when it comes down to logistical implementation, a lot of the devil's is always in the details. Thank you.
Hi, I'm a psychologist, so my core expertise is neither healthcare nor technology, but really human behavior. And when I think about behavior change, I tend not to think in terms of patients or consumers. If you think about a patient, there's someone who tends to be, they need to be told what to do, and they usually need someone else to do it for them, right? You can't do your own surgery. And behavior change is fundamentally do it yourself. You need to actually do it yourself, and it needs to come from a place of autonomy, a sense of freely choosing your own behavior because you are pursuing something that you want, rather than because someone else told you that you need to do it. And when you think of a consumer, that's somebody who has some kind of unmet need or desire, and they can fulfill that need or desire through some kind of economic transaction. And change is a process, not a product. You can't pay someone to help you quit smoking, or you can't pay someone to make you quit smoking, or to change what you eat, or to comply with some sort of treatment. And so when I think about behavior change, I think the first thing that comes to my mind is the degree to which healthcare and the technology sector tend to underestimate the amount of suffering and stress that is behind the behaviors that need to be changed, and overemphasize the degree to which information and incentives or punishments might be able to influence behavior that is frankly already meeting a need and helping people deal with suffering. And when I think about what is required for behavior change to unfold, and I think about the things that technology and healthcare need to support, it starts with autonomy, the sense that people are pursuing something they want, often something that's hard to quantify or measure, that it's not so much the numbers on the scale, but it's the sense of vitality or how you feel about yourself, that we need concrete opportunities to make choices that are consistent with those goals and values. We heard in the keynote how important convenience is, so that it becomes obvious that this decision I'm making right now is connected to this deep goal or value. But at the same time, convenience isn't enough, because when people are suffering, if you've ever met anyone who's ever been addicted to anything, even food, people will dig through the trash. They will stand out in the rain, freezing cold, to get what they want. And that's very inconvenient. And it doesn't matter how convenient it is to, say, not smoke a cigarette. That convenience is totally overwhelmed by the suffering or the stress that is behind the behavior. And the last thing I wanted to raise is the idea that behavior change is fundamentally social. So when I think about technology and healthcare, I think about the importance of establishing relationships that are supportive of behavior change, whether that's changing norms, whether it's recruiting families and friends, whether it's creating social-based competitions and games that allow you to meet your social needs through a difficult behavior change. And also the degree that that relationship with the healthcare provider, it goes so much beyond informational value, like what it would mean to get a text message from your doctor encouraging you, rather than some sort of informal note that you're not following through with your treatment plan. So I hope we get to talk about some of those things.
Okay, thank you all for the introduction. I think all of our panelists have given us a very good idea of where they come from, and we can start our discussion. We'll take 3 questions at a time using the mics in the aisles so that our panelists have some time to collect their thoughts on those questions. So if you could, we can just start with your questions, I prefer. If not, I can start, and then we can take it from there. Oh, okay.
Well, I'm prompted by Dr. McGonigal's little comment about getting a text message from your doctor, and this whole issue of who is going to be providing the health care. Does it have to be from the doctor? Can it be from the nurse? And just as an aside, I am a physician, and I have a son who's in the healthcare system, and I find that transitioning from pediatrics to adult medicine when he became 18, I mean, it's a whole different world, and I think there's a lot to be learned from how the pediatricians take care of their patients that could be taught to the adult practitioners.
Kelly?
Yes, actually, I think it's any human relationship. I mean, there are plenty of studies looking at, you can introduce somebody new who says, my sole role is to help you make this behavior change. And that kind of advocate can be just as effective as someone who's in an authority role. And I also think this idea of looking to pediatrics and how relationships are there to help people deal with such difficult experiences, I think sometimes we forget that when you turn 18, you're still suffering and scared.
Also, to add something quickly, Susan, I don't know if you tried HealthTap, but one of the features that we added about a month ago is health tips. It's actually doctor created. So you tried it? Yeah. Okay. Great. So we have doctors are creating on HealthTap not only answers to people's questions, but also 100-character tips with a beautiful picture that is being sent either by text message or SMS or email to patients for free. And patient can subscribe to these tips. So the doctor is creating them only once. So he creates a stream of tips. So it's only one-time effort. And then the patient can subscribe to it and get 1 tip a day. So it's short, it's immediate, it's to your phone. It doesn't take a lot of time, but it keeps it top of mind. And more than anything else, keep the relationship between the doctor and the patient that the patient trusts, right? So they get it from the doctor. It's not extra effort, and it's the #1 most used feature by patient today on HealthTap. And patients are spending more than 20 minutes per session on HealthTap, part of it because of these relationships of trust and because of this ongoing engagement. So doctors can do it in an effective and efficient way today on HealthTap.
Bassam, what's your view on tasking the physicians with such activities, given that they are already stressed for time and stretched for their attention?
To be honest, I think a lot of it depends on the quality of the technology. If it's, like I said, if it's effective, if someone has a obesity problem or eating disorder or some problem and if the technology is designed in a way that is not very intrusive and with smart alerts and good communication, I think a lot of it will depend on that. If it's simple and effective, and it works, I think they will use it. But just throwing something on an iPhone or a screen or something that demands more of their time, I don't think it will get a lot of traction.
Okay. And Anne, how about financing such endeavors of direct interaction of patient to consumer patient? Is there room for that? You seem to favor the B2B2C approach.
I do, but when you think about the delivery model, I think the doctor doesn't even have to be part of that equation. And I think when you look at the medical home model that's being used and advocated, it's usually a case manager, care management function by LPN or RN or some other, someone else in the nurse practitioner in the practice. So I think there are many ways. Probably the only thing I don't agree with that Mark said was the issue of too few doctors. I actually think if we can bring down utilization and we can more effectively use other resources than doctors, then we're going to be fine. And I think if we perhaps graduate more primary care physicians as opposed to specialists, even better.
Yes, I have a question also directed about patient behavior and behavior change. And the first one is a lot of people talk about gamification of healthcare, and how that engages patients. And my first question is, what do you think of that? And my second question is about behavior change and the difference between that and behavior patient activation. That is kind of another slightly different model. I don't know if you're familiar with Judith Hubbard's work or not.
About patient activation?
Well, behavior change is trying to get the patient to take a certain action, and there's lots of different models. And behavior activation is really trying to just move the patient from one level to another. So first of all, it's really important to recognize where they are exactly, and it's not the traditional kinds of readiness for change model. It's more about very specific to a patient and a patient's particular condition and particular action with that condition. And there are sort of different scales that are associated with it.
So, well, let me start with the gamification. So some of you may actually be a little confused right now. You might be wondering, is that Kelly McGonigal or Jane McGonigal? I have an identical twin sister who is very well known in the gamification sphere, particularly in relationship to medicine and healthcare. So that's not me. And not surprisingly, I have a different point of view on gamification. I think it depends on the population. So gamification is trying to incentivize behavior by making it fun, by creating either cooperation or competition, challenges, adding meaning that is really about the things that make games and play so engaging. And I think when you're talking about pediatrics, children, certain teenage groups, this is going to be extremely effective on its own. I look at places like Hope Lab and their games for helping increase physical activity in youth or helping youth go through chemotherapy. But this is it's a targeted population and an intervention that makes a ton of sense. Now, if you look at the research on how gamification helps adults, it almost always seems to be that it's the social glue that's making it work, and that the gamification is providing a way for people to get together, to either to compete or cooperate, but that it's really those social bonds and the social accountability that seems to be driving a lot of it. And that goes also for programs that are paying people to change, or that have lotteries that you can win if you are sober or you lose weight. That when you actually talk to people who are running those programs or to the patients, or you look carefully at the data, it seems like the social benefit is a lot more important than the gaming content. And so that, to me, that makes a lot of sense. And I think so games are just one way to provide that kind of social glue. And the incentive structure is almost certainly not what's actually driving it for adult behavior change. And then this other model that was described makes a lot of sense to me. My first rule is always start where you are, and that any kind of behavior change is a process that has to engage the individual where they are and what they care about and what is possible in that moment.
And is there room from the investment perspective with games in healthcare? What's your view on that?
I would leave that up to people who are investing in consumer internet companies. I mean, it's really just I do wear my up band that Mark was referring to, and I do think there's value in the social aspects of it, but it's not something we would necessarily be investing in. There was, I don't know if you know Mark Hyman, who's a doctor who's got a very interesting practice, and he did have an experiment in a 1,000-person church in LA that was extremely successful, and it was just based on this theory that the entire church was engaged in essentially a weight loss effort focused on health. And I think that sense of community and that reinforcement of that social network, all the research says that heavy people hang out with heavy people and skinny people hang out with skinny, because you're sort of reinforced by your own social group. So I think that is important, and I do think that talking about it, focusing on it, working it through community is important.
Well, let me just say I'm a practicing primary care doctor, so I find this part really interesting. I wanted your thoughts, if we take a different analogy, because I agree consumer engagement is important in healthcare. So let's go back 40 years and talk about consumer engagement in terms of retirement planning, because it was defined benefit at the time, and now it's defined contribution. And the idea being that if you had skin in the game and you had to make the right decisions, you would choose correctly that your retirement all going to have to face at some point, that we'd invest wisely. And of course, we know from the Employees Benefit Research Institute recently that over half have $25,000 in their bank account. And so as a doctor, I find that particularly worrisome, because it seems like deja vu again, except now instead of stakes of being your money in the bank account, it's actually your health. And unlike retirement, you can actually put off and work longer to make that kitty. That's not always true of healthcare. So I'm trying to really ask, what level of consumerism do we need in terms of learning from the past and not repeating the same mistakes? And what level is that responsibility at the individual level, either the employer level, like the business to business, like designing systems or benefits to nudge the right behavior, and all of it is more of a societal level in terms of what do communities want and what do cities like New York City want to kind of nudge the right behavior. So that's really what I'm asking in a different way. Not talking about healthcare per se, but really like human behavior. And does people really want this responsibility we're kind of asking them to do?
Address from your experience.
So I think that Mark talked about reducing barriers and making it frictionless, and I think that it's like Kelly said. I mean, it's necessary but not sufficient. But we want to start there, and I think that what technology is very good at is creating good infrastructure that will create an opportunity for people to start engaging. We also need to build an infrastructure of trust, because I think that there's, we all know what we should do, and there's so many ways of doing things out there, but we want to get it from someone that we actually trust. We want to get something that is it's reliable and it's about us. So if we get an idea from someone that we trust about what we should do, and the person happens to be a doctor, if we can bring our doctors into the game as well, and you trust them, keeps you accountable, right, in a way that is ongoing without inundating the resource too much, and creating personalized programs to you. And that's the key, because I think that different people will engage with their health in different ways, inevitably. Some people are runners, and some people are completely sedentary. And if they're using the app band, which is a great product, some people will use it in different ways. So the idea there is, if we can create an infrastructure that we have programs that are trustworthy for people and they're different from one another, and make it very easy to access. They're trustworthy, they're easy to access, they're personalized to you. So there's a different program for a runner and a different program for someone that just starts doing certain things. And then keeping motivation by understanding where the person is. Our role is to create the infrastructure for that, and then allow people to engage in any stage that they are willing to engage or ready to change. There was a reference for Prochaska's theory for readiness for change and where people are in the cycle. I think that we should not push people to do certain things, but we need to make it very easy for them to do, and we need to give them the tools and the technologies to actually engage on an ongoing basis.
Are there any segments of the population, from your experience, that are more ready to adapt choice and that responsibility that comes with it?
Sure, it depends for what, right? So it's like healthcare, it's such a wide continuum at the end of the day. And we learned that when we did, BWell at Stanford here, there are people that are considered healthy, and it's all about prevention and what we should do or not do today for something that will happen in the future. And some people that are, pre-diabetics, right? And they are very close to, to becoming sick soon. And some people that are managing a certain condition. For some people, it's just starting to walk or doing a little bit more running or reducing stress. And for some people, it's just taking their medications on time. So we're talking about a very wide array of different kinds of behaviors. And I think that once we give people a variety of options that they can choose, a trustworthy program that they can choose from, and a way to monitor it on an ongoing basis, we will see more people doing it throughout the entire continuum of health.
And, or Bassam, you can go next.
I thought it was a great question. And I think something that's really important to highlight is that a lot of the challenges we face are actually cultural. One of the biggest strengths of our culture is that for any problem, no matter how big it is, there is a solution. And not to sound morbid, but everyone is going to die. And it's a serious issue. When someone is dealing, you could wipe away all the savings from a good lifetime of preventive care with a prolonged ICU stay, a cascade of iatrogenic complications. God forbid anything that happens to, if you've ever experienced this, it's a nightmare. And you don't have choice. You really don't have much of a choice. In fact, forget even the clinical choices that you have, even from the cost choice. Physicians don't know how much their tests cost. They don't know how much the interventions cost. Even if we try to find out, it's really hard. What if there's a possibility of having the test with the price? Well, trying to get that data as well, it really depends. What if you had different options? Those are opportunities for technologies. But the bottom line is that culturally, we're not ready to say enough is enough. And clinically, there comes a point when doing more creates more harm. And having these discussions is really important. I don't know if Mark's still here, but he talked about these end-of-life programs. That's a real big issue. There's a lot of data. I think Himmelstein's group from Boston published in 2007, 2009, and 2011. that over 60% of personal bankruptcies are due to medical related costs. And 75% had health insurance. And he did the same study in Massachusetts after the healthcare reform, and still this problem was there. Over 50% and over 80% had health insurance. So underinsurance doesn't mean if you have insurance it's going to solve the problem. And these end-of-life issues, I'm not saying preventive care is not important. I think it's really important because of wellness, happiness. I think those components are real. But the bottom line is that the cost at the end of life are a very big decision. And how you defined end of life, you could say in your last year, last 5 years. The point is you don't have much of a choice. You don't have that many options, and there's no transparency in cost, not just for patients, but for providers. And until that problem is solved, maybe Castlight could help. Until that problem is solved, we're not going to get anywhere. If you cannot measure it, you can't manage it. Forget it. And that's something that I think, when I forgot the gentleman, I don't know where he's asked, I think it's very relevant because if people don't understand these costs and the options, you're going to be very, it's going to be very difficult. And add to that our biggest cultural strength, which is no matter how big the problem, we'll overcome it. It only adds fuel to the cost fire.
And have you seen any changes in behavior when people are healthy and they are employed and they are invited to choose their benefits? Have you seen a shift in mentality when it comes to choice, or is it a struggle there too when people are healthy?
No, absolutely. And I think we're starting to see this as exchanges are beginning to be put in place privately and publicly, and that is that. I mean, and the question, will this last? People are choosing the least expensive option in general, which is not what people expected. Actually, I think they thought they would choose the middle, option. Well, it's not too expensive, not too low. So they're starting with the least expensive, and it'll be interesting. If you think about it, what's the price you pay for that? Because if you choose the least, but you've got pre-existing conditions, you actually can move up without too much of a penalty. And that's where the system is going to break down because it's the pre-existing conditions issue and not actually paying for the coverage that you really need. So I think it's going to be an interesting experiment over the next couple of years. I do think ultimately, you asked a really great question because I think it's incredibly important to engage the consumer. But the reality is we just have to change the way everyone's paying. Right? The incentives have to be changed because in a fee-for-service system, you are always going to have the wrong incentives. And if you go for a value-based system, then you're going to put care plans in place. You're going to be focused on quality, and then you're going to change behavior. I mean, I think one of the best examples I've heard recently is a group of oncologists who've put together, looked at chemotherapy and many other things in the last 6 months of life. And again, it's the last 6 months of life, so everyone dies. And basically 30% of people who are given it should not be given it. And they pretty much know who shouldn't be given it. So it's not a question of, gee, well, we just didn't know. So they're following different protocols, and they found over the last 2 years that they're admitting they're 51% in reductions of hospital days based on this group's following a protocol. And it's great that we're lowering costs and we're reducing hospital stays, but the reality is, think about the patient. I mean, it's, at least in the last 6 months of life, you're not going through chemotherapy because it really was of no benefit to you. And we know it isn't. And unfortunately, doctors, it's not to say that there's malpractice, but they're not always focused on it. As you say, they've got families that are saying, please, more is always better in the United States. And more is not always better. And I think we've got to change sort of that cultural bent, and we've got to study these things and really be focused on value.
Kelly, any comments on the choice when you're healthier?
I wanted to come back to that. Well, I wanted to come back to the big question, this idea that people can't always be trusted to make the right decisions for their future self. And I think if you look at the science, it's pretty clear that if you want to influence behavior, structural and social changes are the things that influence individual behavior. And at the same time, if you look politically and culturally, people aren't ready for that. this idea that you could get consensus about values that would allow people to endorse structural and social changes that nudge you to do things in your own best interest, we aren't there. So I've been very interested in interventions that create microclimates where people are choosing to do that for themselves, to set different norms, to create structures of accountability, and technology that lets you do that for yourself, like apps that will use your GPS to ding you a special message that you wrote for yourself when you're near the gym or near the Dunkin' Donuts, and that this is a nudge that you've created. But the thing, what all of those require, whether it's at the societal level or the microclimate, like the support group at a hospital, or yourself with your technology, is it requires people endorsing certain values, and that's the conversation that sometimes gets left out.
Mm-hmm. So it's all personally driven in many ways. Next question, please.
Dr. Kadry, so I appreciated your perspective earlier on healthcare and technology. So thinking about your IT platform, if you were to subtract the time that you spend coding and the things that go into finance, the billing, what aspects of your platform, IT platform, do you find helpful? And in particular, maybe talk a little bit about emailing patients and secure messaging. Is that something that's helpful to you and efficient?
So I'm also an anesthesiologist. So that is a very unique perspective because, I don't have a clinic. When I went through my training, I liked all of medicine, but I learned very early on that the overload that a lot of the internists had is something that I didn't want to do. Be that as it may, I have been exposed to, we have, pre-op clinics and whatnot, and it's a significant amount of time. And if there was a way to improve that communication interaction and have it built to take into consideration all the compliance, all the regulatory, all the legal, all the financial issues, then I think a lot of physicians would want to use that. The problem is anytime that you do something different that's not embraced by the organization, you're sort of sticking your neck out a little bit. And it could be for either a compliance issue, HIPAA, it's not encrypted, you can't bill for it, legal, so so even if people want to do it, it's just, there's more risks. And now you start comparing, okay, well, let me just at least speak to this patient on the phone to address their issues. So that's a big reality. I think creating an ecosystem from the hospital, or like I said earlier, a lot of physicians are now getting employed. I think thinking about how, as an organization, are we going to create a platform for our physicians to engage our patients so that they could address either population management issues, not just physicians, the full care provider, like the medical home, how to engage our patients, and if they have a quick question, reassurance, follow-up, what time should I come? It has to be addressed that way, because at the provider level, at an ad hoc level, it's too difficult.
Just to add quickly something on that, I mean, that's what we're doing day in and day out, and we're doing it with millions of people all the time. We are putting patients and physicians in communication with one another, either by asking questions openly, right? So the patient is anonymous and asking a question, and then the physician can answer their question, and then it goes back actually to the physician community to peer review the answer and to say if they agree with it or not. So you don't only get an answer from a physician in this kind of communication, you actually see what the physician community thinks about it. And thinking about it from an efficiency perspective, fast forwarding 8 months forward into Obamacare as part of our reality, with a shortage of more than 45,000 primary care physicians in this country, and very little time for these physicians to take care of all the patients that they need to see, can we create a system in place that first and foremost has physician knowledge for small things that don't require the doctor visit, that can take the doctor's time one time and leverage it many times afterward for questions that are very, very simple and can be addressed without inundating the main resource. And then creating tiers from asynchronous to synchronous interactions, initially using a mobile device. So imagine a world in which you can find answers to similar people like you that were answered by physicians that you trust initially. And if you want to get beyond that, you can actually connect with one physician who's available right now because maybe one of his or her patient didn't show up and they have 10 or 15 minutes available, and you can connect to them to a quick consultation, not a full doctor visit. And then if you need to, you go and see them in the real world. So there are tiers of service that you're getting all the way from completely asynchronous to synchronous on your phone or going to see the physician in the real world. And whether the institution is managing it, which is one option, we're getting a lot of requests. We have physicians in more than 3,000 medical institutions right now. And a lot of them are asking us to help them manage their own population with the system that we created, or doing it in the physician population as a whole. There's a huge opportunity to create a new paradigm for serving people on an ongoing basis in a more efficient and cost-effective way.
Yeah, imagine if that were integrated into your electronic passport as a patient.
Exciting, right?
Yeah, and just one more follow-up. Something that I think also changing very quickly is that the emphasis is no longer just on content, but context. And what I mean by that is that when someone takes the time to engage a healthcare provider, is what they really care about is what's relevant specifically to them. If studies are out there, it's not relevant to them, forget about it. And patients, or anybody for that matter, is if I have a problem and I'm seeking some advice, the person I'm speaking to hopefully could take that context into consideration when they're giving me an answer. So I think technology that helps address the context challenge is technology that would help at the point of care, like you're saying, for all these different types of reasons.
We're talking about physicians, right?
Yeah. Yeah.
Well, it can be done in the patient side as well, because you can personalize answers to patients as well. So one thing that we added about 3 weeks ago was attributes. You can add attributes to a question that you ask a physician, right? So you can say, I'm a male, I'm taking this kind of medications, I have these prior conditions. So we already have answers in the system to more than 98% of any health question that you ask. But now we're diving deep into the personalized answers for people like you. So you can actually dive back deeper into seeing what doctors answered question to people that are similar to you. So adding context to the answer gives you another opportunity to actually serve more people in an efficient way.
Kelly, any comments on the context aspect?
No. That sounds good. I'm excited. I'm like, oh, I didn't know about this.
Okay, next question, please.
Thank you. My name is Pallav, and I'm a trained anesthesiologist. I left a few years ago, a decade, to work for healthcare IT full-time. And I've built the electronic health records and healthcare information exchanges. So I tell you this because my question is from a very particular perspective of a solution builder for, say, consumerized patient tools. I struggle often with the fact, and I've built the conventional tools. I struggle with the fact of how we're thinking about personalization and consumerization of healthcare. And when people say that it's the free tip of the day, or it's on your mobile, and you can have peer reviews, there's a Yelp for your doctor, does anybody in this panel have any shred of doubt that we cannot just port paradigms of consumerization from other industries and just take them to healthcare? Have you, and I'd like to start with you, because I feel like we can all hypothesize about healthcare's consumerization because it hasn't happened yet. So, who knows? My answer may be better than yours. But if you can point to some other industry, and finance comes to an example to me, why does Mint exist? If you can tie something that's very basic about consumerization and start with that, because I fundamentally believe I've built the conventional tool that gets sold for millions of dollars. There's zero consumerization in there. And I don't see any way that, personally, I won't use a Yelp for my doctor. I've used Fitbit for over a year, so good luck for people who are using Up. But it doesn't do anything for me. And maybe because I'm healthy at this point, but it doesn't do anything for my mom, too. So, I'd like to...
How would you, if you don't know who to go to, where do you begin your search to find out where you want to get the care you want?
No, you're asking me as a patient. My question perspective is from a solution builder for the patient. So I'm the B2B to C person at this point. And I want to understand the psychological, if there's any doubt in your mind that, peer reviews are great for healthcare. Maybe I have a cancer that I don't really want peer reviews. And my privacy is more important to me. So I just wanted to kind of start with you and see if you had any contrarian thoughts to what's been discussed over here.
I do. I'm very skeptical about a lot of stuff. Sorry. That's why I'm always surprised when I end up on a technology panel. So I'll just say a couple of thoughts which they're not going to be that brilliant, but when you said, are there any industries that you think of as other models, one thing that jumped up right away for me was politics, in the sense that politics has gotten very good at getting people to do specific things because they have activated some sense of identity and values. And that if I tell you this thing is connected to your identity, the things that matter to you, then I can get you to vote for things and do other things that in theory are consistent with that. I mean, I'm not saying that's an ideal model, but I think that politics knows how to drive behavior by really tapping into using language and using ideas and using role models that will drive behavior. When I think about also the experience of a patient, someone who is confused and scared and uncertain, I think choice can be a real problem because then now you are feeling accountable for making choices that could determine your own or a loved one's outcomes without actually having expertise. And so there's something that's in the middle of what's being described here. I don't want all the choice in the world to screw up a medical decision that then I'm going to spend the rest of my life regretting what I did. That I do need advice, but there's something in the middle between having total freedom to choose and then having to go and sort it out myself versus being able to choose someone who's going to be my advocate and a counselor through it. And so those are just two things that come to mind in thinking about some of the problems here.
Yeah, choice is a huge aspect of consumerism, and there's also social mirror, there's aspiration, and the finance industry has tapped into that somewhat, and the financial aspect drives it. And here we are dealing with insurance that pays for most of our, well, not most, it's changing, but most of our care is covered, and so we are not thinking of our wallet as much when we're making choices. So any of the rest of our panelists who can comment on choice and any other aspects of consumerism, both in healthcare and in other industries?
I think it's a very poignant question because in terms of consumerism, I think you have the outpatient side and the inpatient side. And if you think about the inpatient side, the consumerism model is, I don't think it's really, it's not going to build that much traction because you don't have much choice and there's not much visibility in terms of your cost. But on the outpatient side, I think there is a lot of choices and a lot of options. And you know, and the reason why I was asking that question is because even for physicians, it's hard to know who to go see to get the care that you want. So any product or service that's out there that helps guide patients to that next person to could hopefully answer more questions and maybe guide them to the right place, I think there's value. And I also think as patients become more price sensitive about this, they're going to be more motivated to look at these options. One of the things that I think is concerning is what we talked about earlier is the value-based purchasing and accountable care organizations, and that we'll be able to manage a lot of these costs by capitating them. It's sort of like the whole HMO model. But, you know, again, the devil's in the details. Who gets the good credit or the bad credit? The admitting physician, the discharging physician, the team who took care of all that? And it's just shift risking. In that sense, I agree with you. I don't think there's much the role of consumerism is going to hit that.
So just in light of redirecting back to my original question, I'm more interested in finding what are you guys skeptical about in terms of consumerization and the models that you're supporting. So also, you know, it's great that you started with that, but what do you think may not work for the way that we're approaching it today? That was what I was trying to say.
So I will answer it. I will answer it what I think that will work rather than what will not work because I'm an entrepreneur.
The question.
And I will answer it this way. When you have a health question, which happens to people 1.5 billion times on Google every month, right? You need an answer to this question. What I fundamentally believe in consumerism in any space, not only in health, in any space, that it needs to be need-based. If you attach to a fundamental, deep human need, right, that exists right now in the market and is not solved very well, you have an opportunity for consumerization. Meaning, I wake up one day and I have a problem, medical problem, and I have a problem right now. I'm not in front of a physician. I'm not even in front of a computer. I'm carrying a phone. And I have a health question about me or my child or my parent that I'm very concerned about. This is an opportunity for consumerization. When I have the need, when I want to get an answer to my question, if I can connect immediately, right now, with no friction, with a US licensed physician for free, and get an answer within a few minutes, this is a huge opportunity to redefine how we interact with our health in general. And that's a huge opportunity for consumerization because there's a need and there's a way to fulfill it immediately.
And there is the payment side of the equation. So, Anne, where would patients be willing to pay in healthcare to have those needs fulfilled? And is that payment a challenge then, according to the person who has the question, for consumerization in healthcare?
Well, they're paying now, right? I mean, the reality is consumers pay for alternative therapies every day. I mean, you have a bigger drug industry in alternative therapies than the existing prescription drug industry. So I think consumers are paying for things at that level. I think if you want to say what doesn't work, let's start with. I mean, Castlight works in a model that's currently fee for service. I think if you think about the price of services in America versus other countries, we pay our administrators, our physicians, 30% more than any other country does, and more, even in the developed world. So I think that there are stages of these things, and I think what Castlight will do initially, or products like it in terms of price transparency, is we will have a more competitive market. So it will. You can argue what does that do for the patient, but that is at that level. I mean, hopefully they'll also be focused on quality and other metrics, which will force people to be measuring healthcare in a different way, right? I mean, right now we measure it in a very superficial way. What is quality? So I think that works, but I think ultimately what works is not a fee-for-service system, and so that it's got to be. I would hope that consumers would engage, but that they're working with systems that are thinking about their long-term health.
So we have time. Thank you. We have time for one or two more questions.
I'll try to talk
very
fast.
Quickly.
And it's related to what your question is, so I'll take a little swing in there. And that I think one piece that's not working is ignoring end of life as a huge issue. So I want to thank you for speaking to that. I think one of the things that stood out to me that you were saying is that there's no choice, and I think that there is. It's just there's a lot of opportunity for behavior change within those choices for clinical education and for the way that we as a society deal with that issue. But palliative care is a big part of the solution. It's a big piece of being cost effective. It's also a big piece of quality of life, which is the message that everybody really wants to hear. And then I think it's also advanced care planning is a big piece of this. How many doctors are doing their own advanced directive and dealing with that on a personal level as opposed to being scared to talk about it. So a lot of the research points to doctors not having those conversations with patients because they don't even want to do it themselves. It's bigger than that. But my question is, what are your thoughts on behavior change for the system when it comes to that issue? Because with a third of Medicare spending on the last few months of life and only 2% of that being from hospice, we have a lot of opportunity for behavior change.
I think you're right. I think those discussions need to happen well in advance. And what I mean by not having choice is not that there's no options, but it's just very difficult to get consensus with all the decision makers in the family to figure out what everyone wants. And typically the decision that is chosen is the most conservative decision. I think there's opportunities for libraries of information. Imagine a library of animations describing to families, what does it mean to be on a ventilator? What does it mean to have feeding tubes? What does it mean to have a trach? What are my chances of meaningful recovery? This whole area of end of life is sort of ignored because it's so sensitive. But I think it's something that really is part of our culture. But it's a great opportunity to start focusing on these things. I think I saw Dr. Milstein in the audience somewhere. He's working a lot on ambulatory ICUs and addressing a lot of those issues. So I think this part of the equation is something that we have ignored, and we should start probably investing more time and resources, and not just thinking about the technology, but the whole process in the context of the culture.
Can I add just one quick
Quickly,
thing to that? Yeah, I think this is a perfect example of how economics end up being driven by real suffering that is present, particularly in the family members who are so afraid of doing the wrong thing that they'll just keep doing anything to try to avoid the regret or guilt that they'll feel. and to think about not just in economic terms, but how much suffering would be relieved by what you're describing, so that afterwards the family members feel a sense of peace rather than doubt. So it can help in both ways.
We are almost up with time, but I'll take one more question, a quick one. Very quick concluding remarks from our panelists on that question.
I promise I'll be quick. My name is Jim. I can relate to everybody on this panel, so it's very exciting to listen to you. I'm a doctor. I'm an internist and an anesthesiologist also, and a regular participant on the HealthTap Medical Expert Network. And I'm obsessed with ways to try to keep people together in groups, local groups, either networked or physical groups, to optimize positive health outcomes. I don't see any other way around it. And I just wanted to speak to Ron's company. I really enjoy, if there's a question about consumerism, all you have to do is go on that site and see how many people have questions that they need answered. I really like doing this as a medical expert, quote unquote, because it's process-oriented learning. People learn things when they are motivated to ask questions. It's much like the case method at the business school here. If you have a problem you have to solve, you're much more likely to engage with the information given to you and to make it actionable. The problem that I have with HealthTap is that for the life of me, I don't think my incentives for participating are like those of many other doctors on the site. I mean, I don't have a brick and mortar practice anymore to try to drive traffic to my site. I just really want to be an architect for the future, for the healthcare system in the future. I want it to be right. I want it to be accurate. I want to communicate well. I've had, as you know, in anesthesia, you have people who are sort of need information accurately, and they're very, very much primed to get information. So that's an intimate experience for me. But I'd like to see more doctors participate, and maybe it's not gamification, maybe that's not the right word, but the incentives that you provide on your site don't attract me particularly. I don't need the medals and the points and the thumbs up. I don't need all that stuff. I just need the satisfaction of knowing that I've answered a question properly and carefully. And if you have any information or suggestions about how to motivate people to stay connected locally,
She'll kill me if I answer that question. Right?
You can go very quickly, and then we'll close very quickly.
We should talk offline.
Okay. So thank you all for coming. Any other questions, any more comments? The panelists will be around during the break. You can talk to them more. Thank you very much.